Today let's go through a case of acute abdomen in a young patient of 40 years age. So this is axial Portovenous phase CT of the same patient. We are going to review the scan in order. So looking at the liver looks fine. The gallbladder, whenever we are thinking of acute abdomen pain in young patient, acute cholecystitis is always one of the differential, but the wall is smooth. There is no pericholecystic free fluid or fat stranding. The fat looks very clean here. There is no bile duct. You can see the bile duct here running here. There is no bile duct dilatation. There is no intrahepatic bile duct dilatation. The spleen looks normal. Now looking at the pancreas itself looks fine. There is no focal collection or lesion. There is no pancreatic dilatation. Going to adrenals, this inverted V shape is adrenal on both sides. Over here they look fine. There is no focal lesion. Now looking at the kidney, the left kidney looks of normal corticomedullary thickness. There is no focal lesion, no calculus, and no hydronephrosis. Looking at on the other side, it's same. The kidney is of normal cortical thickness, no hydronephrosis, no calculus, and no focal lesion. We can follow the ureter. So this thin pipe is the ureter. We can follow it down up to the bladder, and there is no focal, no calculus or hydroureter. Now going down further, we will see the bowel. Superficially first, we can see some of the bowel loops are distended on the left side, small bowel loops, but this seems to be within normal limit and there is no surrounding inflammation. But going down, we can see this focal area of inflammation, and further down this corresponds to the sigmoid colon, and now we will track it from below. So this is the rectum going up, that's the sigmoid colon we can see, and slightly going up we can see the sigmoid colon is thickened here. There is surrounding fat stranding and trace of free fluid. Interesting thing to note is that these few gas locules within the inflammation. So overall these features are suggestive of acute diverticulitis with complication of localized perforation. Sometimes we see few lymph nodes, reactive lymph nodes, though I am not seeing any large lymph node here. Now looking at other things, so the aorta is of normal caliber, the IVC looks fine, there is no retroperitoneal or para-aortic lymph nodes. There is no pelvic side wall lymphadenopathy, and the portal vein, which is here, this also looks fine. There is no thrombus or gas in the portal vein. Another important thing to know is to look for appendicitis in young patient with pain. So if we come down, so this is the ascending colon, come down, and now we are at the cecal pole. Looking anteriorly at the cecal pole, we can see this thin tube coming out. So that is the appendix. If you see, it is running now here, and it will end. It just turns back and then ends as a blind loop over here. So there is no abnormal distension of appendix, no surrounding fat stranding or inflammatory changes. So there are no features of appendicitis. Finally, we will zoom out, change it to bone window and look for the bones. So the bones look fine. There is no focal sinister lesion. We will see the pelvic bones as well on both sides. They are also looking fine. We can go and check pelvis in axial and also check lower lips in axial. So we are almost done with the scan. Only thing remaining is the lungs. So now looking at the lungs are clear. There is no pleural effusion, and looking at the mediastinum, the heart size looks normal, and there are no other significant findings of note. So now we have finished this scan. Our final diagnosis is acute appendicitis with localized perforation as complication. We will urgently call the surgeons and give us our finding in this this patient can be managed conservatively, or if not doing well, then they can decide to